Good. I'm Pol de Saedeleer. The immune system is the biggest determinant of overall health and longevity. So, a lecture on the immune system. Maybe a short introduction first on longevity medicine. So what's the goal of longevity medicine? And the goal is actually to reduce the gap that exists between lifespan and health span. That's what we do with longevity medicine. A lifespan, as you know, is the total life you lived. Health span is the period you were free from disease. And so the goal is actually to close the gap. Now, according to statistics, we're not only seeing that the population has grown to nearly 8 billion, but we actually also see that now, currently, 25% of population is what we call aged. So it means 70 years and more. Now, forecasts predict that by the year 2100, 80% of the population will be aged. So that in mind, well, we understand that medical care will develop to something different with room for prevention, a lot of room for prevention. Now, talking about reducing the gap between lifespan and health span, currently and statistically this gap is now 9 years or a little bit more than 9 years, and the goal is to reduce this gap. Now, the leading cause of mortality and morbidity is chronic disease. Cardiovascular disease is number 1, cancer number 2, we have diabetes and chronic respiratory disease, and they account for 80% of chronic disease related deaths. So in longevity or health span extending strategies, we can do two things. First, we can address the factors that still can be modified, like excessive weight, physical inactivity, diet. And next to this, there's really a lot of room for prevention, and prevention means that you do things before tissue damage showed up. Now, talking about immunity, the key points of my lecture, I will show you how the immune system works with the innate and the adaptive immune system. We will talk about Th1, Th2, Th17, the role of the regulatory T cells. It's very important. We will spend some time to show you what regulatory T cells do also in the prevention of excessive inflammation or autoimmune dysfunction. But then, in the context of longevity, let's see how the immune system is affected when we age, and let's also see if we have strategies to counter the effects of aging on the immune system. Good. So, the immune system, two parts. First line, the innate immune system, and then the second line, the adaptive immune system. And in the innate immune system, well, we have an immediate immune response. It's non-specific, it's a fast and immediate response, and non-specific in that sense that we will not really identify the antigen. In the adaptive immune part, there the immune response is more sophisticated, more specific, with prior identification of the antigen. Good. Let's start with the innate immune system. And the innate immune system, the immediate immune response, it's not only natural killer cells and phagocytes. No, different physical and chemical barriers also are an important part of our first line of defense. Our skin, for example, or the mucous membranes that cover the respiratory tract, the urogenital tract. In the mucous membranes, well, pathogens can be trapped and expelled. But also different secretions like tears, sweat, saliva. They protect us, they defend us because they contain anti-infectious agents. And do not underestimate the role of stomach acid. Stomach acid is really a very important first line of defense to prevent intestinal infections. On the level of cytokines, well, we have interferons, we have interleukins. They are the messengers in our immune system, and also the complement system is a part of the innate immune system. It's some kind of collective of proteins, and they can, when they're activated, they can eliminate antigens and induce inflammation. Good. Well, key players in the innate immune system are the natural killer cells. So the natural killer cells are fast and efficient. They eliminate antigens without prior identification. So if your NK cells, if your innate system works well, you're pretty well protected. Now, NK cells are activated as soon as they detect infected cells or cancer cells. And infected cells are identified because molecules like interferon 1 are released. So the infected cells are identified as an antigen. And then NK cells, well, they break down the membrane of the infected cells. They use enzymes like perforin to break down the membrane of the infected cells, and this is how they eliminate the infected cells. And simultaneously, they also release interferon gamma, what we will need also to develop the adaptive immune response. Good. In the adaptive immune response, well, we first need to identify. We identify the antigen to make sure that we have a really good, sophisticated, more personalized immune response. Of course, setting up the adaptive immune system takes more time. Identification, well, the main identifiers are the antigen-presenting cells or dendritic cells, some kind of specialized macrophages. They have receptors like toll-like receptors, and they really identify specific parts on the antigen. And as a result of the interaction of the identification, well, the antigen-presenting cells will present specific fragments, specific information on the antigen on a display. And this display is MHC2. This is how they provide the information, the specific information to the T helper cells. And then, depending on what information gets in, well, we develop a flow of cytokines, what will finally allow a differentiation to Th1 cells, cellular immunity, or could be a differentiation to Th2 cells with B lymphocytes, or Th17, and of course do not underestimate the very important role of the regulatory T cells. They have an immune regulatory function. They need to make sure that everything we do on immune level is in balance, that we don't see excessive reactions. Good. Going more in details into the Th1 response, the cellular immunity, well, we see that the cytokine that drives the differentiation to Th1 is interferon gamma. So interferon gamma promotes differentiation to Th1 cells like CD8 cells, but interferon gamma will also activate and recruit macrophages. Interferon gamma prevents differentiation to Th2 to make sure that we have a good, powerful Th1 response. And it's important to understand that the CD8 cells or the Th1 cells, well, after a while they undergo cell death. So as soon as the infection is under control, they undergo cell death. We only keep a couple of memory cells, and the memory cells can be reactivated if a similar infection shows up, to make sure that we rapidly control the situation. We also have specific markers, receptors on Th1 cells, CXCR3 receptors, and it's actually as soon as the receptors on Th1 cells are activated, the CXCR3 receptors, well, the Th1 cells know that they have to move to the site of the infection, and the same receptors can also be used for proper identification. Good. The CD8 cells, to eliminate the infected cells, well, they use a method that is similar to the NK cells. They also release enzymes, the different enzymes, to degrade the cell membrane of the infected cells. And yeah, the main difference between CD8 cells and NK cells is that here we need identification. We identified the antigen, of course, via the antigen presenting cells, but also identification on the level of the infected cells, because all the cells, all nucleated cells, they carry MHC1 receptors. This is also a way for CD8 to identify. So comparable with NK cells, but here we first identify the antigen. And you'll see that CD8 cells and NK cells are great partners, for example, in cancer prevention and in cancer treatment. So they really work together to compete cancer or intracellular infections like viral infections, so EBV, HSV, but also mycoplasma, Borrelia, and more. Good. Another option, depending on what kind of antigen or pathogen we face, is the development of Th2. In Th2, the immune response is different. So we don't destroy the antigen, no, we produce antibodies. So the B cells here release antibodies, different kind of antibodies. The first to be released are IgM. They only live for 24 hours, but they are produced all the time. And usually 1 week, 10 days after IgM, we have IgGs. So here we don't destroy anything, we mark or we neutralize. And in the Th2 response, the typical mediators of allergy are also recruited. So the eosinophils, mast cells, basophils, they will also release IL-4 to make sure IL-4, more IL-4, that we have a good, powerful Th2 response. If we talk about allergy, well, some antigens can initiate the release of IgEs, like dust, pollen, vaccine adjuvants. They can initiate the release of IgE, and IgE and the antigen, well, they then bind the surface of the mast cells, and the mast cells are activated, and this is a real allergic reaction with release of histamine and other mediators. In other courses, we will talk more in detail about mast cells. We will also talk about mast cell activation syndrome, but I think for now, in this introduction, I think it's important to understand how mast cells are activated in allergy via IgE. Good. Another option next to Th1 and Th2, depending on what kind of antigen we encounter, is Th17. And this is the immune response that we see, for example, in fungal infection. So Th17 is induced via a combination of different cytokines. One of them is IL-23. So remember IL-23, because I will soon also give you more information on IL-23. It's one of the cytokines that we use in development of Th17. And of course, everything is kept in balance via regulatory T cells. Regulatory T cells have an immune regulatory function. They maintain immune tolerance, and they make sure you stay tolerant to your tissues, and they prevent autoimmunity. Differentiation of Treg cells is the result of a combination of cytokines, and remember here that IL-10 is one of the cytokines to induce Treg cells. Okay, this is the mechanism, Th1, Th2, Th17, depending on what antigen, and the major role of the regulatory T cells. And I actually would like to share more information on the mechanism and the role of Treg cells, because if Treg cells are not strong enough, if they're deficient, well, in literature we say, okay, if your Treg cells are not strong enough, you lose tolerance. You lose tolerance, and that's the basis of autoimmunity. So from a pure immunology standpoint, autoimmunity stands for poor Treg cell activity. And let's see what the underlying mechanism could be. What could be the cause of poor Treg cells? And the first situation is genetic. You have an autoimmune dysfunction because your parents had an autoimmune dysfunction. So here we see, for example, a mutation on the level of the transcription factor that codes for the Treg cells. So genetic. Good. Number two, the situation that contributes to autoimmunity. Well, number two might be a powerful Th17 response. And this is extremely important in the understanding of the immune system. It's actually the dual talk between Th17 and Treg cells, because if we have a powerful Th17 response with IL-17 cytokines, we automatically suppress Treg cells. So you have a powerful immune reaction on a candida overgrowth, and this actually could induce a reduction of Treg cells and an autoimmune dysfunction. This interplay is very important to understand. My number three shows the initiation of autoimmunity in pollution, in poor diet. And once more, here we focus on the interplay between Th17 and Treg cells. What is the introduction? Well, in the introduction, I show you that if you have mice manipulated in a lab, manipulated in that sense that they have an overexpression with IL-23, and you know overexpression in IL-23 means very powerful Th17 response. Well, in these mice, you see automatically that a very powerful Th17 induced by IL-23 is suppressing Treg cells, and yes, mice develop autoimmune dysfunctions like Crohn. Okay, shows the interplay between both. In the same experiment or study, we see that if you block IL-23 with monoclonal antibodies, okay, you stop the reduction on Treg cells, and you see that mice with psoriasis actually feel better. There is a reduction of disease severity if you use monoclonal antibodies. But, so my question is, should we use monoclonal antibodies in a general way in autoimmunity? Because if we use monoclonal antibodies, if we block Th17, Treg cells are more powerful and we reduce autoimmunity. Well, my answer is no, because if you block IL-23 with monoclonal antibodies, and if your Treg cells become stronger, well, they might become too strong, and too strong Treg cells is not adequate, because if Treg cells are too strong, they could actually finally also have an immune suppressive effect, for example, on Th1. So they could, for example, be responsible for reactivation of Epstein-Barr or herpes. So it's not that easy. It's not just blocking IL-23. The monoclonal antibodies have been used, have been developed as pharmaceutical drugs in the treatment of psoriasis, but effectively, often we see EBV reactivations. But this is purely to show you the mechanism between Th17 and Treg cells. Other real-life circumstances where we see an overexpression of IL-23 are air pollution. Air pollution is a rise in IL-23 and higher risk for autoimmune dysfunction, or heavy metals such as cadmium, arsenic, lead. They can also promote IL-23. This is actually the literature that makes you understand how pollution is higher risk for autoimmune dysfunction, something that we suspected for long. But also poor diet that contain a lot of salt, sodium salt, can also increase IL-23 and contribute to autoimmune dysfunction. Good, so the immune system is shown to be the biggest determinant of overall health and longevity. Sure, if your immune system doesn't work well, it's difficult to be healthy, and it's difficult to do real longevity. So the goal is that your immune system works well, appropriate, what means an immune response should not be too weak or too strong. Everything should be in balance. Okay, let's try to understand how the immune system is affected in aging. Because we expect that aging is actually correlated with downregulation of the immune system. And in aging, we will see two effects that I would like to show and detail you. The first effect that we see when people get old is the inversion of the ratio CD4-CD8. I will soon show you. But also we see a shift from Th1 Treg to Th2 Th17. That's what we expect in aging. And let's try to understand the mechanism, because if we understand the mechanism, we probably also know what the options are to counter the effects. Good. The inversion of CD4-CD8. So CD4 are the immune cells that orchestrate the immune response. That's where the differentiation starts. And normally we need to have more CD4 than CD8. So if you're in good health, your CD4-CD8 ratio is between 1.5 and 2.5. Now, what are the conditions in which the CD4-CD8 ratio is inverted, is actually less than 1? Well, an obvious situation is HIV. It's HIV because in HIV the virus breaks down CD4, so automatically the ratio is inverted. Now, statistically, how many people have an inverted ratio? Well, normally it's less than 10%. In aging, it's doubled. And in general way, we can expect that inverted CD4-CD8 ratio predicts a higher risk for chronic pathology, but also morbidity and mortality. Okay, what clinical solutions exist to promote CD4-CD8? Let's cover what the options are. Let's start with immune modulators, and immune modulators that we like to use not only in prevention, but also as a supportive treatment in infections are peptides. And what kind of peptides? Well, transfer factors. And transfer factors, and that's my job now to make you understand what transfer factors exactly are. What transfer factors are peptides or amino acid sequences that T lymphocytes release during the immune response. Okay, so the goal has been to extract the transfer factors, because if we extract the transfer factors, well, we could possibly transfer immunity from someone exposed to someone not exposed. Okay, goal is now to extract transfer factors when the immune system peaks. And in the first studies, in the first literature, Lawrence, Kirkpatrick, well, they used leukocytes. Leukocytes were actually transferred from one human to the other. Now, currently, we start with colostrum, because colostrum is also a moment where the immune system peaks. But it's a very high purification, HPLC, where we finally only keep the proteins with a relative weight below 10 kilodalton. This is, per definition, these are the transfer factors, and the research clearly demonstrates, as I will show you, that transfer factors work much better than whole colostrum, of course. Now, in what circumstances are we using the transfer factors? Well, first circumstance is to activate NK cells. Remember, NK cells are efficient, fast, and non-specific. If your NK cells work well, you're very good protected. So, transfer factors can activate the NK cells in that sense that you're better protected in a non-specific way, what offers a lot of benefits in prevention, but also in complicated, complex chronic infections. So NK cells work better. Good. The other indication is using transfer factors to transfer cell-mediated immunity. And doing this, and also referring to the literature, we can see that in patients with low CD4 counts, like HIV patients, well, you can, make CD4-CD8 ratio better, but it's also a very good tool that we use as an immunomodulator in patients with suppressed immunity, like cancer patients. We use transfer factors also even in autoimmune conditions, or referring to the studies I show you here, to address opportunistic infections in cancer patients. So a lot of options and opportunities. What's the research? Well, here the research with the first composition, with peptides or transfer factors, clearly shows the effects on NK cell activity, the effects on lymphocyte activity, but also you'll see that IL-10 goes up, so Treg cells support. You will not induce autoimmunity using multi-messenger or transfer factors. You will just make your NK cells much more powerful. So we use transfer factors in prevention, but also in chronic infections to, for example, shorten the regimen of the anti-infectious treatments, or, next to antibiotics, antivirals, really to support the immune system. This is the first composition. It's also clinical training today, so I think it's good also to show you what tools you have, what tools you can use. Multi-messenger, and I refer to the published study. It's normally 3 capsules just before breakfast, and so here the goal is really NK cell activity. The second composition is messenger complex 2. It's a composition with a mixture of different transfer factors, so that's what we really use in the adaptive immune system. Next to the transfer factors, well, we also have different forms of inositol and beta-glucan, so it's a powerful inducer of the adaptive immune system, and often we combine multi-messenger, especially in chronic infections, EBV reactivations, Lyme patients, all patients with suppressed immunity. And so multi-messenger 3 capsules before breakfast, messenger complex 4 capsules before sleep. Good other options that we have next to the transfer factors to empower immunity to work on the ratio CD4-CD8 is, of course, address the underlying infection. So if HIV patients have low CD4, well, antiretroviral therapy will repair CD4. Makes sense. But also lifestyle advice, dietary management. You can't supplement yourself out. I think we need to understand the mechanism behind pathology, and this is how we can really choose the molecules that we use. But dietary management and lifestyle advice need to be a part in a real progressive form of functional medicine or longevity, and this is what we also need to do in immune optimization. So CD4-CD8 may be used as an integrated marker for biological age. Another aspect that we see in aging is the shift from Th1 Treg to Th2 Th17. So that means that when people are getting older, Th1 is less efficient, and Th1 is what you need to eliminate infections like viruses. Your Treg cells are important to keep the balance. Well, so they're both disrupted, and we have more Th2, so more allergy and more autoimmunity. This is statistically what we see, what we expect. And it's important to understand that behind this, well, genes actually only matter for a part, maybe 10–20%. Lifestyle and dietary factors are much more important here. It's the difference between genetics and epigenetics. And for example, emotional stress like loss or divorce or whatever have an extreme impact on immunity. But also sleep disorders, toxicity. So all the other factors are so important, and finally, together, much more important than genes. And so every kind of therapy needs to be a complete therapy that includes lifestyle factors and dietary management, with, of course, the use of good advanced and researched molecules. Well, actually, the information that we're sharing today. Good. So we see the shift to Th2 and Th17 in a general way in different pathologies. It's been researched and published also specifically, for example, in fibromyalgia and in chronic fatigue. And behind this shift to Th2 and Th17, of course, we see that thymic activity declines. Thymic activity declines first when you're young, between 15-20 years, but there is a real sharp decline once you're 40-45. And thymic activity is inversely correlated with disease. Now, chemicals, pollution. Chemicals also affect thymus and cause immune disruption. Okay, going back to the balance, Th1 Treg cells, what are the methods if we really want to empower Treg cells? And empowering Treg cells is really makes sense in a complete multisystemic treatment of autoimmune dysfunction or excessive inflammation. And I like to refer to butyrate short-chain fatty acids. And why do we refer to butyrate if we want to empower Treg cells? Well, I listed 3 different reasons why butyrate is a very powerful tool in excessive inflammation or autoimmune dysfunction. And my first mechanism or reason is actually the fact that butyrate inhibits the deacetylation of the histones. So butyrate has an epigenetic activity. By doing this, you increase the expression of the transcription factor that codes for Treg cells. So butyrate has an epigenetic impact to empower Treg cells. But butyrate is also the fuel, the energy source, not only for intestinal cells and also for Treg cells. And finally, butyrate also promotes interleukin-10, what really drives your differentiation into Treg cells. Essentially, butyrate, next to the supportive effect on Treg cells, butyrate has a very well-published, studied effect on gut permeability on different levels, actually, on secretory IgAs, on mucin, really on gut barrier function in a general way. The only criterion is that we need to make sure that butyrate is delivered in a bioactive way. That's a challenge, because if you take butyrate such as, it will not work. So we have a vehicle that delivers butyrate in a bioactive way, and this product is registered under the name of Butiflam. And the regular dose is also referring to the literature, is 3 times a day, 2 capsules, what corresponds with 3,000 milligrams. So in autoimmune dysfunction, gut hyperpermeability, there's also a lot of research for butyrate actually in neuroinflammation, referring to the gut-brain axis. Now, a short addendum from my part on butyrate, actually extra information, because I think that this molecule deserves more attention, and also referring to the recent publications where butyrate was also more and more advised in optimal health and body weight management. So, obesity and excessive body weight is one of the main challenges that we have to face nowadays. And we believe more and more that our microbiome might be the link between the environmental factors and the onset of obesity. Just to give you some numbers, currently 39% of population world population is overweight, 13% is obese. It's really a much bigger problem nowadays than underweight people. And we see clearly that in chronic pathologies, in obesity, we see that the synthesis of short-chain fatty acids like butyrate is altered. Or if we do fecal transplant between obese humans and germ-free mice, well, we see that mice also become obese. So what are short-chain fatty acids? Well, short-chain fatty acids, not only butyrate, but also acetate and propionate, are fermentation metabolites. Fermentation starts from fibers, undigested fibers, and it's accomplished by colon bacteria, by butyrogenic bacteria. There might be a controversy, yes, if you only measure butyrate in stool, you might suggest that butyrate levels are elevated in obese patients, but it's not the case. But if you see elevated butyrate levels in stool sample of obese patients, it's not because there is more production, no, it's more referring to poor absorption and utilization. So don't make your conclusion purely on stool tests where you measure butyrate. So the fermentation depends on butyrogenic bacteria. We all know Faecalibacterium progenitii, but also Roseburia and Bacterium rectale contribute. And in looking for solutions, it's important to know that cross-feeding exists between Bifidobacteria and Faecalibacterium progenitii. So that means that if you use Bifidobacteria, your Faecalibacterium progenitii goes up and also your synthesis of butyrate. Why do we have a lower abundance of butyrate? Well, food, diet, westernization of lifestyle, too much sugars, proteins, antibiotics affect our microbiome, drinking alcohol, smoking. So we need to go back to good essential food that contains a lot of fibers like cooked potatoes and raw bananas. And not only in obesity, but also in other pathologies like autism, for example, we see that the synthesis of short-chain fatty acids is altered. Now, if we use butyrate or butyflam also in the context of body weight management, well, we actually refer to the fact that butyrate is acting on intestinal receptors, inducing the synthesis of GLP-1 and peptide YY. So using butyflam, GLP-1 goes up, or insulin-resistant markers go down. So that's great. This is actually what we need to address the comorbidities in obesity, but also to work on appetite, for example. And referring to the effects on GLP-1 and insulin resistance, we also see studies where butyflam was used in lean subjects, 4 grams a day, so 4 times a day, 2 capsules, where we also see the effects on insulin sensitivity and fasting glucose. What about the effect on PYY? Well, PYY inhibits appetite. PYY is not leptin, and that's good because leptin, you know, in many obese patients we see resistance to leptin. Leptin normally, as soon as leptin hits the hypothalamus receptor, you should inhibit hunger. Or going back to the essence, the adipose tissue that we have is releasing leptin, and the levels of released leptin always correlate with our energy stores. So you had a food, your adipose tissue is releasing leptin, and then normal circumstances, leptin goes to the hypothalamus, hits the leptin receptor, and you inhibit hunger. This is how you control appetite and reduce appetite after a meal. But we see that the system often fails. Leptin resistance is what we see regularly in obese patients, or in environmental toxicity with plastics, we see that leptin receptors sometimes are damaged. So PYY works on another level, but finally the goal is also to reduce appetite. So basically, Butiflam, you work on GLP-1, you work on insulin sensitivity, but you also work on appetite. But there's more literature, and you know, I could talk for hours on butyrate, so I just show you a couple of essential things. So the effects of butyrate on tight junctions and gut permeability, but also the effect of butyrate on lipolysis, on liver enzymes, on mitochondrial biogenesis. So it's really very diverse. Good. So I hope this information is useful. So we covered the immune system, the way the immune system is affected when we age. We covered also a couple of key solutions, and we also showed you or gave you information on the options that exist with molecules like butyrate. Thank you.